Hi everybody, how are you? It's Dr. Emily, podiatrist, human movement specialist, founder of EBFA Global, and inventor of Naboso technology. So I'm going to shoot a video to talk about hypertonicity. Now, hypertonicity is obviously the opposite of hypotonicity, and these are terms that perhaps are more used in children. And when you're first getting introduced to movement, you may have a child that is hypertonic, which means they're almost spastic. Some children are born with a little bit more hypertonicity or spasticity to their tissue. I would say that that would be a super mild form, kind of in the direction of cerebral palsy, not all the way to that extreme, but cerebral palsy is an example of a hypertonicity in a neuromuscular muscular system. The opposite is when you have children who are hypotonic, and the hypotonic children are usually, you could think of them as ligament lax, low tone babies, almost need to be activated. They're a little bit sensory sleepy in a sense. So that's typically how you would hear these words used in children. Hypertonic baby with low tone, a low tone baby, or a hypertonic baby that's on the edge of spasticity. Now, when we go into adulthood, and probably a lot of our clients, I know a lot of patients that I actually see are hypertonic. So I see them coming into my office. I just saw patients Friday that presented with this. Has, of course, very high arch. So seeing the high arch, I knew his foot was rigid. And then knowing he's complaining of knee pain, I can just see the way that he's standing, that he's going to have limited ankle mobility, probably partly because of the high arch cavus foot, where you start to see an association, but also just the way that he was presenting, and I saw him carrying himself, that I knew that he was going to be a little bit more in the direction of rigid, spastic hypertonicity. So of course, when I go to see him do a squat, an overhead squat, he's dropping his chest, showing me that he has limited ankle dorsiflexion. When I go and I do an open chain ankle joint assessment, I see that he does have restricted ankle mobility, and it is not a bony block. So when I'm doing the open chain assessment, I can feel that it's more of a soft tissue restriction. What I do is I put the patient all the way into maximum ankle dorsiflexion, and then I'm palpating along the Achilles tendon and through the belly of the gastrocs, and see the way that those muscles feel under tension. And you start to see a pattern with those hypertonicity patients. When I see him do a gait assessment, or saw this particular client doing a gait assessment, course, he was walking and he was pounding his heels, and I could hear him walking all the way across the room. So again, that goes with the high arch cavus foot, limited ankle dorsiflexion, hypertonicity. I also saw compensation patterns of his walking, limited ankle dorsiflexion. So bring him back into the office, kind of speak to him about what's going on. He tells me he stretches, gets no effect. His feet are tight, his ankles are tight, he's getting really bad knee pain. He started getting a standing desk, and it's just really killing his feet. I'm helping him to understand that his structure, his physiology, and I often say his reality, right, that we need to work within, is that he's on the side of this hypertonicity. He's really quick to get tight, yes? So if he's quick to get tight, it's important for me to explain to him that hypertonicity, you have to go after the nervous system. If you simply do static stretching and traditional stretching, and your client does have hypertonicity, remember, it's going into the nervous system. Static stretching, passive stretching is not going to get into the nervous system. So I need all of my hypertonicity patients to do much more effective releasing through their soft tissue neuromuscular system. If they're doing trigger point release, they're going to get a much higher effect than if they do static stretching. And this is some really good research that came out of the World Fascial Congress a couple years ago, which related to cerebral palsy, spastic hypertonicity condition, and they looked at the effect of static stretching on that mobility versus trigger point release and more of a myofascial approach to that. Saw much greater effects with the myofascial approach or trigger point release because we know that it's targeting much more of the nervous system. So my recommendations and my go-to products for any of my hypertonicity patients is you want to get into the nervous system. There's different ways that you can get into the nervous system. You could do just traditional myofascial release, get a lacrosse ball, a golf ball, a foam roller, a grid. I don't care what product you use, but you're getting into that soft tissue with myofascial trigger point release, and you want to make sure that you're doing it appropriately, whether it's a pin and stretch, etc. If you're not doing traditional SMR, trigger point release, then we want to look at some of the other options. We want to consider sensory stimulation, which is why I'm on the Naboso mat, and I recommend all of my hypertonicity patients to use sensory stimulation during their myofascial release. So they would be doing it on a Naboso mat. For this gentleman, my patient, I had him use a Naboso mat at his desk. So when he's standing, he's addressing the hypertonicity of his standing desk through sensory stimulation through the feet. You of course can use the Naboso insoles as well. A little tip or kind of connection of the effect of Naboso insoles, hypertonicity, and what it can do to range of motion is when we look at idiopathic toe walkers. This is another example of hypertonicity. Idiopathic toe walkers, so whether they're children all the way into adulthood and they have an early heel lift, they have a very bouncy gait, you can tell that they're really quick to lift that heel, short, maybe narrow strides. What is happening is it's going again through the nervous system. This is a neuromuscular reason of why they have this idiopathic toe walking. Look at sensory stimulation in your programming and in your release for any idiopathic toe walker or early heel lift gait client. Now, some other products that I will use and that I recommend to all of my hypertonicity patients is vibration. So the vibration, a couple different options that you have. One, you can use power plate. So I have the personal power plate. I have one of these in my office, and I recommend them to all of my patients, particularly those who have hypertonicity. You can either simply lay the calves. So let's say if you have hypertonicity in the lower extremity, in the foot and the ankle. Typically, the most common muscles to see a lot of hypertonicity is going to be the gastrocnemius. So legs are on here, you're simply relaxing. I'm gonna turn the plate on while I'm talking. So it's just vibrating and I'm relaxing, yes? So the vibration is creating an inhibitory effect on the muscle spindles and the GTOs, causing that relaxation, which is amazing. Now, if your client does not want to invest in a power plate, it may be worth investing in the power plate, or maybe they have access to a gym or a rehab facility that does have a power plate or a whole body vibration platform. There's other products that are available. One of my favorite is by Hyperice, and they have several different products. I don't have all of them here available, I'm sorry, but they have a Hypersphere, which is a ball that vibrates. So think like the effect of what you would do with a lacrosse ball, but with a vibrating ball. You could also use Vyper, which is their foam roller, which vibrates as well. There's different settings. Now, the different settings that you use, you actually want to match the different muscles that you're on. And I don't know if they go into that from a detailed perspective, but if you are familiar with Vyper, if you're not, head to hyperice.com. But the Vyper has 3 different settings. Now, every muscle vibrates at a little bit different frequency. Your calves lower down to the ground, or think smaller muscle compartments, they vibrate at a lower frequency. So you could do setting 1 or setting 2, so a little bit lower vibration. As soon as you start getting to these bigger muscles, your quads and up more kind of upper part towards your trunk, that's where you want to go to a higher frequency, and you'd want to do probably setting 2 or 3 to get that release. So you're combining the vibration with the myofascial release. Perfect, because you are combining the inhibitory effect of the vibration with the inhibitory effect of the SMR. If you are not familiar with their third product that I'm going to recommend, which is the Hypervolt, this is something that I just got at NASM Summit. This is highly, highly recommended. It is $350, so it would be an investment, but it's actually really easy to do and use on some of the other parts of the body that maybe some of your clients, if they do have a true spasticity, it's going to be difficult for them to get on the ground and off of the ground, which makes doing myofascial release very difficult. So Hypervolt, super easy. We turn it on. It has 3 different settings, and then you're releasing whatever. I'll go to my calf, right? And then you're releasing it. You can do very, very light if you want, and then you can increase the intensity, which of course is increasing the frequency of the vibration. Now, another added benefit that I actually really like with the Hypervolt is you could use this for a lymphatic stimulation. When you're doing lymphatic stimulation, you want to go as most distal from the body, and you're working up to the heart. So you would be almost like painting your muscles with the Hypervolt. So this isn't really even getting into like a heavy massage. I'm just painting my muscles with the vibration, which a lot of our people, especially those who like to pound out their muscles when they do myofascial release, might not think anything's happening, but it absolutely is, superficially and through the lymphatic system. So as a little recap, hypertonicity, you want to be thinking of this as a spastic. It's almost like a pseudo-spastic condition. An extreme version of a spastic condition is cerebral palsy. So just know there's obviously gradations of everything. But the way that cerebral palsy is addressed based off of the research and their spasticity is through trigger point release and addressing it through a neuromuscular approach versus static stretching. I would also do much more in the direction of this versus static splinting, like a night splint or a Strasbourg sock or something like that. You want to, again, remember that you're going through the myofascial system. So all the way cerebral palsy into spastic, hypertonicity, and then those are just your really tight clients. You could also start to profile them and say, you know, do you gravitate towards like quick power, right? Usually people who are on the edge of spasticity and hypertonicity can create very quick power. I'm an example of one that I like to do really quick movements. I was explosive gymnast. That's just the way that I traveled. If I do not do myofascial work such as this in this way, my muscles gravitate towards tightness. That's the opposite of, let's say, someone who's like a contortionist and they can go into, you know, different Gumby positions. That's obviously the opposite. And in that case, we would be focusing on activation and stabilization, again, through a neuromuscular approach. Different tools, different modalities. You want to think of it how you're doing it from a sensory perspective. Real quick wrapping up, the patient that I had seen on Friday, he had a little reset routine that I said, this is going to be your go-to. So I need you to release the bottom of your feet, your soleus, your anterior hip, so that we're doing this on a daily basis, and you're going to use one of these vibration tools, and then you're going to use the Naboso insoles in your shoes, and you're going to be doing your release on the Naboso mat. That's going to have a much higher efficacy than stretching statically, or doing SMR a couple times a week for like an hour and just randomly at the muscles. Yes, I hope this helps. If you have any questions, I am always available on social media. To learn more about myself and my practice, please head to dremilysplichal.com. Until next time, stay barefoot strong.